Thank you. Next up, we have the Health Department. Excuse me, if you guys are leaving, do it quietly, please. Thank you. Thank you. Please proceed.
Good morning, Council President Clark and members of the City Council. I'm Dr. Tom Farley, Health Commissioner. Joining me are Jane Baker, Chief of Staff, and Sammy Jarrah, Chief Operating Officer. You have my written testimony. I want to first thank my wonderful staff that are with me here today and just highlight a few areas. The Department of Public Health continues to provide high-quality primary medical care at 8 health centers. Last year, we served over 74,000 patients in over 336,000 patient visits, about 40% of which were for the uninsured. In the past year, Health Center 10 was recognized as a patient-centered medical home. We're now applying for the others to get that same recognition. We're adding exam rooms at Health Center 10 to serve more patients. We are working with other agencies to respond to the opioid crisis. The Department of Public Health is focusing on reducing inappropriate prescribing of opioids, expanding medication-assisted treatment for substance use disorder in primary care, and preventing fatal overdoses. This budget requests funding to help physicians to start offering treatment with Suboxone, as well as funding to purchase naloxone to reverse opioid overdoses. One of the many consequences of the opioid crisis is the sharp increase in infections from hepatitis C, which can be spread through injection drug use. In recent years, this previously untreatable infection has become curable. This budget requests funding to help people with hepatitis C get treatment and reduce the spread to others. In the past year, we published our first annual Health of the City report, which summarizes Philadelphia's most important health problems and the factors that contribute to them. We continue to address the leading causes of death demonstrated in that report, chronic diseases like heart disease, cancer, and diabetes, by working to reduce smoking and promote healthy eating and physical activity. I'm proud that the Health Department has a diverse staff. Among 872 staff members in full-time positions as of December 2017, 76% are minority race or ethnicity. People who are bi or multilingual make up over 18% of all full-time staff, with Spanish the predominant second language. Our staff members speak a total of 48 languages. And I'm happy to answer any of your questions.
Thank you very much. And thank you for your brief testimony. Appreciate it. In your budget detail, section 43, you highlight a $45 million increase in air management services in the Grants Revenue Fund. Can you kind of talk to me about what that's all about?
Yeah, the Volkswagen settlement. This is something that the Volkswagen company has to pay to try to remediate some of the air pollution problems across the entire country and maybe in other countries as well. So there will be funding coming to Philadelphia to replace diesel equipment that puts out fine particle air pollution and other equipment. We don't know how that money is going to be channeled. Some of it may come to city government for our own equipment that we own. Some of it may go to city government, which would then be granted potentially to other entities to replace their equipment. Some of it may not come through the city government at all. So what this does is simply enable us, if we were to get granted that funding, to receive it and be able to re-grant it. We wouldn't spend that money unless we received the Volkswagen funding.
Okay, but you need appropriation Something that's very important to us, we've been working on for a while, community schools. Can you give me an update on where you are in terms of your department interacting with the school district and the Mayor's Office of Education, if any at all?
Yes, so we do. Our chronic disease division works with the community schools, people, and the school district in general to support, where we can. We're focusing a lot on health promotion within schools, make sure they have healthy food, access to water so that kids are drinking water rather than sugary drinks. We have a specific initiative in the Health Enterprise Zone District to have community health workers that can help get consent for parents for some health services like vision care and I'm forgetting about the other services that often where the barrier is simply getting the parental consent. So we're doing that, try to facilitate that process. And so those are some of the things we're working on.
Talk to me about Gideon. Involved? Yes.
So we understand that there's an interest in some sort of health services being provided at Gideon Elementary. And we're working with the Mayor's Office of Education and the school district on a request for information from service providers about what sort of models could provide what sort of health services in the school. There is a consultant that is working on actually writing the request for information, and we're working with her and the other agencies on the content of that. Okay. And when we have a draft of that, we'd be happy to share that with your office because I know you have an interest in that.
All right. Yeah, I'd really like to see. I know I think you were at the meeting, one of the meetings that I attended, Eva.
I'm not sure if I was there, but my staff was there.
Yeah, that's probably should have been. That's important because that particular school, one of the most significant focuses of the community schools model is healthcare. As you know, that area where Gideon is high concentration of asthma and other healthcare related issues, and I really like to see you at the table.
Yes.
I'm sure if I ask you, we'll be there.
I'll be happy to attend any meeting on that.
Thank you. Chair recognizes Councilman Jones.
Thank you, Mr. President. Good afternoon, Commissioner. To President Clark's point, there was an interesting article yesterday or maybe even the day before where more and more parents are using school nurses as their primary form of treatment for their children. And so that relationship to public health, because of budgetary constraints at a lot of our public schools, I don't know how you're going to attempt to fill that gap, but it would be an interesting dialogue between you and the school district. My question, however, is over the years, there have been at our public health centers a particularly long wait for service. Have we cut that down? Have we been able to shorten the time between someone making a major request to see a doctor, physician, or other, and the time they actually get seen? Because you, in those cases, are, and you mentioned 40%, are the last line of public health defense for them. How have we attacked that waiting
So
time?
we are the provider of last resort. We welcome patients who don't have insurance or anybody who's in Philadelphia. And we're glad that we are popular. So we have an increasing number of people coming to our doors. And the limit on the number of patients we can see is less how much staff we have and more so the facility. There's only so many examination rooms that our doctors and nurse practitioners can see. And so, in particular, at Health Center 10, that's a facility, an area where there's been a lot of immigration, a lot of people who want those services. And so we continue to have long waits there.
So when you say long, quantify for me.
So
what's the average?
Let me just get the numbers that I have in front of me here. Right, so if you are a new patient at Health Center 10, well, first I should say, if you are sick and you want to come in and be seen that day, we will see you that day. We set aside time for sick visits on the same day. However, if you are a new patient and you don't have an emergent issue, it's 131 days for you to get to that first appointment. It's about half that if you are an existing patient and you want a repeat appointment. But we know that that is absolutely too long, and so we are working to expand the number of examination rooms so we can see more patients. There's a renovation that is planned and is going to start relatively soon that will add 12 additional exam rooms. That'll increase the number of exam rooms by about 50%.
So understanding that logistical problem, as I am, somebody waiting over 100 days for an ailment, one or two things is going to happen. Either going to get better on their own or get worse because of the wait. And so, we're going to continue to ask that question and urge you to work towards, shortening that time. Your role in the safe injection site theory, I'll call it. What's your role going to be?
So I am working on the opioid crisis along with commissioners of other agencies to try to address as many ways as we can to reduce fatal overdoses, prevent people from becoming addicted in the first place. And so this is a strategy among many other strategies to reduce fatal overdoses. And so I was part of the group that reviewed the evidence for this, part of the group that went to Vancouver and saw a facility there with our own eyes, and part of the group that said, yes, we think a facility like this would be a benefit to Philadelphia because it would save lives here.
So the resident expert, in my opinion, in this body is my colleague, Helen, who has traveled abroad to a number of these sites. But what I want, if someone listening to this, when they walk in one of those sites, what will they see? And specifically, what will be the monitoring at a site like this and public safety monitoring of a site like this, just if in the best case scenario?
First, let me explain for people who may not know what a facility like this is about. We're calling it a comprehensive user engagement site. And it's a facility for people who are injecting drug users who, for whatever reason, despite treatment availability, are not going into treatment and are continuing to inject and therefore are putting their lives at risk every time that they inject. And the idea is to engage them, to encourage them to go into treatment, and to keep them alive until they are ready to go into a treatment. And so facilities like this around the world provide supervision of that injection so that instead of it happening on the street where kids could see it, it happens inside a building. There are medical staff on site, and if they have an overdose, the site can administer an antidote so that it doesn't become a fatal overdose. And so these sites are pretty plain. They just place opportunities, booths where people can inject and staff around to help them. But then there's also wraparound services there, people to counsel them, people to help them with their maybe shelter needs, as well as direct them into treatment, or potentially actually have treatment on site. And these facilities have absolutely been shown to save lives. In the 15 years the Vancouver site has been open, they've had thousands of overdoses and not had a single overdose fatality on site. And there's been scientific studies to show that they've reduced the total fatal overdoses in that neighborhood. And it's not the solution to the problem. There is no one solution to this overall crisis, but we feel that it's an important piece of the overall strategy.
Is there some type of form legally that we're going to say, to mitigate liability, that somebody's family does not come back after the fact? How do you minimize that exposure legally?
I'm not sure what you think the family might be coming back for. I mean, in terms of if there's a fatality, we would think that these things are going to prevent fatalities. That's the experience around the world. But let me just say that what we've done is review the evidence and review specific sites and said we think Philadelphia can benefit from this. We're now in the discussion about how would it actually happen here in Philadelphia? Who could operate a site? Where could the site be? How could it be funded? All those issues, and we're having extensive community conversations. We've had a number of community meetings. We have more planned. So all the details about how a site like this would actually operate in Philadelphia are yet to be worked out.
What is your role with the city solicitor holding some of these pharmaceutical companies accountable? What role will you play statistically or medically to try to hold them accountable for this crisis?
Yeah, I'm glad you asked that question, because a lot of the reason we're all here with this crisis is that for decades, doctors have been writing too many prescriptions for opioids. And that didn't just happen. That happened because they were egged on by the pharmaceutical companies that made money from those prescriptions. So that I worked with the city solicitor and his staff on developing the scientific evidence and putting it in a clear way in the what was put together ultimately as the lawsuit against the pharmaceutical companies. I'm hopeful that lawsuit will be successful, but I'm ready to serve as the expertise I have in this to consult with them as issues come up during the case.
So would you say this is large as the tobacco effort, and obviously tobacco was a slower bullet. This has a more immediate impact, but would you hold them
certainly
similar?
Yes, so there was a multi-state lawsuit against the tobacco industry, and this is the Philadelphia's lawsuit is a single lawsuit. It's not part of a group of lawsuits at the moment. But in terms of the magnitude of the problem, it's in the same range as tobacco. It's absolutely huge. And we feel that the pharmaceutical companies bear responsibility to change their practices so that they don't continue to contribute to the problem and to pay for many of the problems that we've all been discussing here this morning.
I'm going to segue because she didn't put the clock on me. You did? Oh, shucks. So, by way of, it was mentioned, community schools, your role. I want to segue to prisons and your role. Returning citizens that may have been on medication inside, may have needed behavioral health issues. How do we make that transition? We had a wonderful announcement today that we will be closing the creek, they used to call it, when I was coming up in barbershops. But it also indicates that we're going to be doing more outpatient kind of thing. Are you guys ready for that kind of onslaught?
We are working with the Department of Prisons closely on I think, very exciting things that they're doing to address the opioid problem from their vantage point. An awful lot of people who use opioids get arrested at one time or another. To us, that's an opportunity to get these people into treatment while they're in jail and then to have them continue treatment when they leave. They have now instituted for all the women who are arrested, they are routinely screened for opioid use and started on treatment while they're in jail. And they're soon going to be expanding to all the men. They're also giving them naloxone on the way out the door so that if they witness an overdose, they can help someone else, or if they overdose, someone else could use theirs to save them. So I think there's a great opportunity there, and I think they're doing a great job, and we are doing whatever we can to help them through that.
One more? Can I? No? I'll wait for the next round, Madam Chair.
Thank you so much for complying with the rule. Thank you, Councilman Jones. So if we could now move to Councilwoman Blackwell.
Thank you. I'll only take a moment. I wanted to thank this department, the commissioner, and those with him. And he's also been helpful and came out when we've had various African and Caribbean affairs as well, and we are grateful for that support, and we need it, and we thank you for that extra interest. And that's all I have to say, and being there for us. Thank you.
Thank you.
Councilman Don.
Thank you, Madam Chair. And, good afternoon. I just want to have a couple of questions. Your budget's about, request is 156 million, I believe, roughly.
Thereabouts.
What percentage of that is state and federal versus city?
The 150 or so is the city funding. In addition to that, we have about the same amount, maybe 130, 140 million in grants from state and federal sources.
And this 18.9 is just from the state, basically, that you're asking for, this increase?
The 18 million that's an increase in there, that's the revenue. Yeah, what that is it's a little bit complicated. There's the Medicaid program where federal dollars are drawn down based upon a match of either state funds or local funds. And we found that the funds that the city currently puts into providing services in our clinics, we can match that with federal funds, and that'll draw down additional funds for for us to use for public health services. So what this does is they just simply put that up to the state, and then it will come back to us in revenue. And so we wouldn't put it up unless we knew we were going to get that brought back and more in addition.
So we found a way to be more efficient in getting reimbursements to the tune of $18.9 million.
We found a way to be more effective in drawing down federal dollars, yes.
Yeah. Is there any way to file back on that for more money?
No, I don't think we can do that retroactively.
Have we looked into that, though?
I will look into it. I don't think so. I'm looking at...
We should look into it. It's
okay.
A lot of money. I would definitely look into it, because what you're saying is we had an opportunity to do this before, but we didn't do it. Now we realize we can do it, and we're doing it. So we've lost that. I look at it as a real positive, but I'd like to see if we can get that 18.9 from prior years where we didn't get it.
Okay, we'll look into it.
Roughly, how many health inspectors do we have in the entire city?
You know, we have different sort of inspectors for different issues. For restaurants, we have approximately 35.
35?
Yeah, approximately, yes.
And how many food establishments and public spaces, basically, are they responsible for, each inspector?
They're not assigned a specific restaurant to go back to repeatedly. They are assigned whatever restaurants are in their region are due. And so I don't have numbers of restaurants or that.
So it's by geographic area, basically. They're assigned sections of the city?
I'm sorry, say that again?
They're assigned sections of the city?
Yes, they're organized by regions of the city.
Okay. And it said in your budget, talked about some lead-based paint, but I was just wondering, does your department inspect the PHA housing for lead-based paint?
I'm sorry, ask that question again. I didn't.
Does your department inspect PHA, their housing for lead-based paint?
Do we expect PHA housing for?
Inspect for lead-based paint.
Oh, PHA inspects their own housing for lead-based paint. Yeah, we don't do those inspections.
So they do that. They do inspect it, though.
Yes, they do.
Okay. And over the 4601 Market Street property, has your department budgeted or spent any money over the past few years to the renovation of that property?
No, we haven't.
Zero. Okay. Okay, thank you. Thanks for your testimony.
Thank you.
Thank you. Thank you, Madam Chairman.
You're very welcome. I have a follow-up question to Councilman Jones' question around the opioid crisis that our nation is facing. At the urging of Councilwoman Tasco, I joined the National League of Cities a few years back, where municipal leaders across government and departments convene annually to discuss major issues, to find out what best practices are. I'm curious to know if health commissioners of, say, the top 25 cities around the country have ever thought about, come together to issue an official statement in the way that you just did with regards to pharmaceuticals and the opioid crisis, so that that collective thought rises and bubbles up to where state and feds need to hear it, to know that, to hear the position that you articulated quite eloquently, I thought.
I do talk to the other health commissioners of big cities. There hasn't been a discussion about having some official statement about the responsibility that the pharmaceutical companies bear, but we can certainly look into that.
I would encourage that type of groupthink, because I do believe it would have great value, given that the nation is grappling with this and cities across the country are struggling with this disease. And with that, we'll move to Councilman Green.
Thank you, Madam Chair. I want to follow up on some questions that have been already asked to this panel. Good morning, everyone.
Good morning.
Based on your commentary, I don't want to presume, but I would ask you to state for the record that we do have an opioid crisis in the city of Philadelphia.
We absolutely have an opioid crisis.
And in that regard, we should be trying to use all resources that we have at our disposal to make sure that those that need treatment can receive treatment.
Yes.
And do we, based on the hearings I've been able to attend, I know you were at the last hearing in Councilman Sanchez's district, from my understanding that there is a significant amount of people on a daily basis that need treatment, but we have a lack of resources to provide that treatment on a daily basis, especially in reference to beds, wet beds, from my understanding.
You know, My agency doesn't run the treatment system. The Department of Behavioral Health does. But I can tell you this, that there is and there are available slots for treatment. So we are trying to figure out why it is we have people who need treatment, who say they need treatment, but are not taking advantage of our slots. What's the mismatch between there? And that's something we're trying to sort out. There are people who say they want beds, but they don't necessarily need beds, and inpatient treatment slots are extremely expensive. And so, again, it's not my department, but if the Department of Behavioral Health were to put all of its dollars into treatment beds, then the number of slots for treatment would go down substantially. So they're looking at what's the mix of treatment slots that are most effective.
Well, I'll be asking similar questions to the Department of Behavioral Health. Are you aware of the number of referrals that are going into treatment slots that are coming from our criminal justice system?
I don't know the answer to that question.
Okay.
You have to ask them that.
So last week I introduced a resolution calling hearings for our Law and Government Committee to have hearings on whether we should be continuing using THC, which is the chemical, as you know, is found in cannabis for screening for people who are on probation and parole. My understanding from some of the research I've been doing is that from a criminal justice perspective, we have been making referrals for people that come on a screen for THC to treatment. And I think that is one of the issues that we have when we talk about an opioid crisis, and we need to have all the available resources available. Having people who come up on a THC screen who are going through a probation and parole process, putting them into a treatment program when that should be treatment being more readily available for those who have opioid addiction, I think is a problem and a concern. And it goes back to the point you made a few moments ago about a mismatch between those that have availability for treatment and those that need treatment. Are you at liberty to comment?
So now I understand where you're going with this, and I agree that having people mandated for treatment who are marijuana users, if that displaces the opportunity for people who are addicted to opioids, is a problem.
Okay. So we'll be looking to have hearings on this issue. I'll be also asking our behavioral health officials as well and getting their perspective. And as we move on to this issue, because I know in other cities like DC, New York have gotten rid of using THC for screens. And I think that's a way of reducing our expenses and also providing more resources for those who really have an opioid addiction like the crisis you talked about. Want to also talk about some points that Councilman Jones had made reference to, and you said you're doing some capital improvements in our health centers to expand the number of examination rooms?
Yes.
Okay, and that will increase examination rooms by about 50%?
That's for Health Center 10 specifically,
For Health
yes.
Center 10. And there are no health centers north of Health Center 10, which is on Common Avenue, correct?
No other health centers?
No health centers north of Health Center
Correct.
10, which is located at Common Avenue. And I would venture that Common Avenue is probably the lower part of Northeast Philadelphia.
Yes.
So when you look at the map of the city of Philadelphia, there's a large area of our city that is not covered by a health center.
Yes.
And when you think about that, we have a 25.7% poverty, which is not limited to some parts of our city, but our entire city. The fact that we need additional health centers, to me, is an issue and a concern. Prior to you coming into this office and in previous administration, working with Councilman Tasco, who was the chair of the Public Health and Human Services Committee, we created a health center authority. We have not been able to use that municipal authority the way we wanted to initially, because we were trying to create a FQHC, but there were some legal liability issues. But I was curious from your perspective if you can opine on whether the concept of using that authority to either create an FQHC or do some type of P3 partnership with other entities to create more health center opportunities in the city are feasible.
Yeah, I'm not enough of an expert on the legal issues to know whether that mechanism is the right mechanism. I can say that there are spots in the city where there is more of a need for primary care, and definitely that area is a spot that is more of a need of it. And whether the city provides it or other FQHCs provide it, we have a need there that we need to fill.
Well, what made me think of this concept of P3s, we're currently doing a P3 project with PGW for our liquefied natural gas facility. I had a chance to attend a conference earlier part of this year in Dallas where they were discussing P3 ideas and a whole wide area of concepts, and healthcare was one of them. I reflect on the South Philadelphia Health Center, which was a joint initiative between CHOP, the Recreation Department, Free Library, and Health Department, where we brought multiple entities together in one location. But I have some perspective on some of the challenges with that initiative, especially going forward in reference to maintenance and the challenges of maintaining that location. So that's what made me think of P3s as a concept. And when you have the growth of some of these urgent care facilities are now starting to come into the city of Philadelphia, there could be some perspective in that regard to investigate how we could look at that.
Yeah, thank you. So I'll just say this much. We are also, we're very happy with Health Center 2. It's a beautiful facility. The partnership, we think, has worked out well, and the patients love the facility. And we're open to arrangements like that and other sites like Northeast Philadelphia where there is more need. We need to have another partner because CHOP played a really essential role in that.
Right.
But we are open to partnerships, and if you have any suggestions on that, we'd be happy to follow up on them.
Exactly. Okay. A few other questions before my bell will ring. I noticed in your budget detail that there were dollars allocated for electronic health records, and I wanted to get some perspective on what steps were taken regarding EHRs.
So we have been implementing the electronic health record called eClinicalWorks in our health centers over the past several years, 3 or so years, and we're just really now sort of finalizing the last pieces of it. There's still some additional connections and additional modules that need to be put in place, but we're close to being finished with that. And it's overall successful in providing information that's better information for our own providers as well as being able to communicate with others.
So can you just describe how, you said you're in the final phase of the implementation of that system. So can you give a description of how that system works from a HIPAA perspective as well as information perspective? So
it's all part of the HIPAA covered entity, which is the health department, and so all that is protected by HIPAA, which means that there's the electronic protection so that information it doesn't get out otherwise. But there's still mechanisms within that for us as we need to communicate, for example, to transfer a record to a hospital.
Emergency room or hospital, right?
Yes.
Right. And so you're able to provide information from a health center, say from a health center 10 to a health center 2, as well as if someone has had a trauma situation, let's say at Einstein or Temple University, and they previously had been in a health center, that information can be provided.
Certainly, any patient who's in our system at all, the information is available to all the providers, regardless of which center they go. The connections to individual hospitals may not all be in place now, but it certainly has the capabilities to set up those sorts of connections.
Okay. Thank you, Madam Chair.
If we could now move to Councilwoman Kim.
Thank you very much, Madam Chair. So I think within the Philadelphia schools community, many families were heartbroken when a beloved teacher at Meredith Elementary passed away from asthma, which, made, again, very clear how profoundly asthma can impact whole communities, and especially our young people, how profoundly inequitable it is in terms of how the consequences that people of color in particular bear on it. And so what efforts is the health department doing right now to support individuals, especially youth, to address asthma-related issues, to tackle some of the physical conditions in our schools that some feel have contributed to that situation, and how do we compare nationally around some of those efforts?
I can't tell you much of what's happening in other centers, but I can tell you what we're doing, and that is, first of all, I very much agree that it's a big problem. It's the primary pediatric health problem we have, major cause for hospitalization, and there's a huge disparity by race and by income. So it's low-income minority children who are suffering the most. Fortunately, we have a model for how we can reduce asthma hospitalizations that was developed by a researcher or by a clinician at CHOP that shows if you go into the home and do a variety of fairly simple things that can be done by a community health worker and also through education of families, you can substantially reduce hospitalizations and emergency department visits. And in the process, you save enough money from the health plan perspective that it more than pays for itself if the health plan pays for that service. So with that idea in mind, we are working with all the Medicaid health plans in the city and CHOP as well as other service providers and primary care providers to try to come up with a system so that health plans pay for this home-based environmental remediation service, because then everybody wins. The health plans save money, the children get services, and they're less likely to have asthma exacerbations.
Could you give a little more clarity? What exactly will the community health worker do when they go into the home?
So they
evaluate the quality of the home in terms of the
right. They look for asthma triggers, which can be mold, can be dust, can be secondhand smoke, and it can be pests. A lot of it is some mice and cockroaches, which is it's a housing problem. And these are allergens, which then the children are exposed to every day, and that's what makes them wheeze. And there are some simple steps that won't make those problems disappear, but if they can reduce them, then they reduce the asthma triggers, and kids are less likely to have an exacerbation.
And how do you work with the school district in terms of school facilities to evaluate? I mean, I know it's a totally different environmental situation, it's facilities that are different, but how do we also take a look at that? Because I know we've had a serious situation around mold decaying facilities. You know, some of it's lack of maintenance, some of it's within the district's control, a lot of it can be major rehab work that needs to happen.
We haven't had the resources to really work, at the individual school level or even the system level about asthma triggers that are in schools. I know that Dr. Bryant Stevens at CHOP has done some of the work in some of the schools, but it's just something we haven't had the resources to do. We do think that most of kids' exposures are more likely to be at home. It doesn't mean that there might not be some contribution of schools.
And are you looking to expand the program? What is the, sounds like you're starting on it.
My goal is to have every child in the city who has had either one hospitalization for asthma or 2 emergency department visits for asthma get this service. And to do this, if we can do it right, it wouldn't cost the city any money because the health plans should be able to pay for it and then they achieve a savings. So that's the goal. How long it's going to take us to achieve that, I don't know. A lot of it is coaxing the health plans to actually put these contracts in place and realize the savings and then continue to invest.
Mm-hmm. And what's the scale of young people that we're talking about currently?
How many children are currently
that could potentially be impacted by your measure? One hospitalization.
It's certainly in the thousands. But I can't tell you more precisely right now.
Well, if you feel like City Council can do more on that effort to be supportive, the Children and Youth Committee would be very interested around that. That's very important. So there's also been increased attention on birth outcomes for Black mothers and babies. There was a pretty profound article, as you know, I'm sure you saw in the New York Times Magazine recently, that showed that Black women are 3 times more likely to die as a result of birth complications, and that these are, not differentiated across like educational experience or privilege or class. It's a dramatic issue. Black women with college degrees can have the same birth outcomes as white women graduates or 8th grade white women graduates. So I know the health department has a maternal mortality review committee. I believe you take a look at disparities along income and race lines. Some of our advocates have asked, what more can we do? I'm sure you're familiar with New York City having piloted a more privately funded study that expands it to look beyond just mortality, but also at non-fatal serious outcomes. Are there some things about what more the city can do in this area?
So Philadelphia is one of the few cities that has a maternal mortality review team, as you said, and that includes every birth hospital in the city that we are in communication with. It looks at these cases of maternal deaths to say, okay, how can we prevent these? To give you some sense of numbers, we have about 15 women who die each year, either around the time of birth or in a year after birth. That's the maternal mortality. Of those, maybe 6 or so are pregnancy related, so the numbers are relatively small. Nonetheless, there definitely is a racial disparity on that, as you said, and the studies on this suggest that the effects of racism across a woman's entire life ultimately can play out in terms of how she responds to pregnancy and puts her at greater risk. And so we are seeing, how can we intervene? There are individual opportunities for improvement that are sometimes identified through that review process. But it's not immediately obvious what the birth hospitals can do, categorically differently to reduce that further.
I mean, a couple of the questions are, the Serena Williams story, for example,
Yes.
shows that though maternal death can be avoided, there's certainly very serious complications that occurred that are non-fatal. Right. So is that something that the Maternal Mortality Review Committee might expand to also include to better understand the scope of what women are experiencing to the point where it gets to the situation of death?
It's a fair question. Should we be looking at some forms of morbidity as part of that as well? And so let me look into that and see.
I think that's one of the questions that a number of advocates are asking about. Another question that people have been asking about a little bit, or advocates have been asking about, is about some better access to data, that there are some limited administrative data sets that some of the advocates can access. But they would like to see if more data that is housed primarily within the Commonwealth of Pennsylvania, they would need permission to do more deeper analysis of things like specific diagnoses, case rates, patient demographics, home zip code by specific hospital. Is that something that you could work with some of the advocates about in terms of communicating with the Commonwealth of Pennsylvania to open up more data to yourself as a department, right, and then make public?
I would certainly be happy to talk to them about that. So we don't own that data, then that would be owned either by the hospitals or if it's billing records by the payers. Obviously, there's a lot of protection on medical data for good reasons. So they're on privacy protections. And so when you get down to very small numbers, that can identify individual people. And so there's a limit to what you can do because of that. But I'm a big believer in making data available. If there's a way that we can help out, I'd be happy to. Okay. And, just similarly, back to the Maternal Mortality Review Committee, I think the New York Times study, I think, other studies have just, as you said, documented the profound impact of racism. It's not just like how a woman responds to pregnancy, but how she is treated throughout her prenatal care, her pregnancy, and through birth, that there's a level of indifference that can happen. One question has been raised about the role of doulas in the care of women through their pregnancy, and whether there's ever been any exploration around supporting an expansion of that program, whether it avoids complications or death by women who are vulnerable, and is there any possibility that Medicaid might be considered as billing for publicly funded doulas? Yeah, so we are supportive of doulas, and doulas, there's a doula program run by the Maternity Care Coalition, and it's, I don't know the exact numbers, but I think it's more available here because of that than in many other places. As far as Medicaid reimbursement, that's up to Medicaid, and we talk to them, but we certainly don't control them, and they may have some concerns about the ultimate cost of that. But we are definitely supportive of the idea. And you'd be on record as being supportive for Medicaid potentially being billing for that? I think I'd want to look into the numbers more and the evidence of impact before I could go on record as saying that it should be Medicaid reimbursable. Yeah, so I think I will make sure that my time closes, but I think that question of it's hard to reform a racist system. It's just, we've done, we're in it, it's difficult. And so finding some of these alternatives as we work our way through correcting broader systems, it seems like it's worth its support, and I'm glad that you're supportive of it, but would like to see if there's more that we can do in that area. Okay. Thank you.
Thank you. Good afternoon, Councilman O'Neill.
Thank you, Madam Chair. Dr. Farley. I just wanted to bring something to your attention that I'm not sure you're aware of, but I think would be very helpful to you. It's actually several of our department heads that have their feet either all in on the county side of our operations or at least partially. Okay. And that is that the National Association of Counties, and we're one of 41 counties over 1 million. So it's the populations change and get greater when you go from cities to counties, because we've been a member of the National League of Cities for a long time, where we're one of the larger cities in that. But the NACO, the city had dropped out at some point, either during the Street administration or the Nutter administration, and for whatever reason. But in the last 4 years or so, since NACO had a new executive director come in, dynamic, young guy, data-driven. They've done remarkable things, and they are doing remarkable things. The city has agreed, the mayor has agreed to get back in to NACO as of last week. And one of the things I know they've done a lot of work on is the Obama administration, through the League of Cities and the Association of Counties, set up a opioid task force about, I'm going to guess, about 2 years ago, maybe 3 years ago. And it expired at the end of the Obama term, and the Bloomberg Foundation picked it up, and it's continued. And I just think that's just one area, but there's a whole lot of areas where they are seriously data-driven on criminal justice, mental health, and any county item, issue that you can imagine, both solutions and then best practices. And if we can jump back into NACO with both feet in the deep end of the pool, I think it would behoove us. And I just mention it to you because we're kind of behind the curve in having not been involved as many of the other large counties are, and sometimes we don't even realize we're a county as well. So just for information, because it's topical and current as well.
Okay, thank you.
Thank you.
Councilman Teutenberger.
Thank you, Madam Chair. Commissioner, I want to thank you and your staff for some good work. It's not easy. Health is without question one of the important human rights. It's also a very important subject in a large city. So I do thank you, and your office has always been very responsive to my questions and needs. I have one simple question. It's probably a question that people don't like to ask, but I want to ask, and it is in regards to asthma, but it also, I think, is a subject that your department has jurisdiction, and correct me if I'm not, is rat control.
Yes.
And do you believe it's been effective? And if so, how and why? And what are your measurements for the effectiveness of that?
Rats have been in big cities for probably as long as they've been big cities.
Well, that is correct. And that will continue. I know that.
And so as long as there is food and water and places for rats to nest, there's going to be a certain number of rats in the city.
Absolutely.
And so our staff go out and treat when there are specific problems. They try to address the burrows. They put out baits to kill rats. That can reduce the problem. Nothing's going to eliminate the problem.
No, well, I didn't ask for zero tolerance on this one. I understand. But on the other hand, it's a battle that is probably ageless. I mean, it just will always be. But I just wanted to know if you think things are going well or not with our war, never-ending war on rats.
Yeah, I would say things are pretty much status quo. That we do manage to keep them far less than they would be if we weren't around, but we certainly don't eradicate them.
Okay. Commissioner, thank you so much.
So we're going to take a break, right? Okay, we'd like to alert all who are here that we're going to now give our stenographer a needed break, and we will recess until 1:40. Thank you very much. Thank you, Commissioner.
So am I finished, or you want me to come back?
I think well, actually, we will have to ask you to come back, as a couple of members have indicated an interest. Okay?
That's fine.
Forgive us.
Hi, how are you? Thank you.
Good to see you. Commissioner, when you have a moment, I'll come over to you. It's a little bit of rats, and there's more to it, but I'd like to be a, yeah.
All right, I will set up a time with my
Okay, well, that would be fine. It's actually animal control. I want to see if something else can be included in that. No, it's, well, you did, well, no, it's not. You actually do it. Yeah, I'm looking for that.
Thank you for coming back, Commissioner. Councilwoman Reynolds Brown?
President Clark, early in his questioning during the last round, asked about community schools. Can you just share with us again where the health department is on the ground in community schools and how well the presence of the health department has ramped up in those community schools that are in a real tangible way active and engaged? Please.
Yeah, I know we're working with the coordinators in those schools about the health promotion activities that take place in those schools to help kids stay healthy. We are working, for example, to make sure that water is available so kids can drink water instead of sugary drinks, the foods be healthier. And then in some of the community schools, we're working to get parental consent for services that need parental consent and where there's an effort for that. For example, to be able to coordinate asthma care, to make sure they get their vision screening and that they follow through, they get glasses if they need glasses, things like that.
So is the presence, is there a health department professional on the ground in a tangible way, or services as needed, as dictated or designed by that community school coordinator?
In general, the community schools, there's not a full-time health department staff person there. There are, I want to make sure I get this right, so hang on a sec.
Surely, of course.
Okay. There are 7 community health workers in 4 of the schools that are doing these promotion activities that do report on up to the health department.
Okay. All right, the last question, I was in a meeting with a healthcare provider, and the question or discussion came up of the HPV virus and how numbers are down with regards to young people not taking that vaccine. So is our department involved in that issue in any way at all, either on the information side, its importance, or the actual delivery of the vaccine?
Yeah, we absolutely are involved. Our main involvement is to make sure that the healthcare providers are giving the vaccine to their patients. That's both, it's not just our clinics, but all the healthcare providers in the city. And I think that information may not be correct. I think our vaccination rates for HPV, human papillomavirus, continue to increase.
Okay, so would you then say, as the lead professional in this area, that there's no need for alarm?
I wouldn't say there's need for alarm. We need to have continued attention because it's still a relatively new vaccine, and so not everybody is getting it, but I think we are improving it, and we can continue to improve that, our vaccination coverage rate.
So would you attribute that to lack of education and information about the value of that vaccine?
I think that the gradual improvements are as increasingly people do recognize that. So there probably are still some people who don't understand the value of that vaccine.
Okay. All right, then. Thank you. That's it for me, Mr. Chairman.
Thank you, Councilwoman. Councilman O.
Thank you very much, Mr. Chairman. Good afternoon, Commissioner and team. I just have some questions for clarification so I have a better understanding. In terms of performance measurements, for example, health analysis, information and strategy, FY19 strategic goals, distribute 20,000 plus naloxone doses throughout Philadelphia, maintain department's national accreditation, develop an annual report on children's health in Philadelphia, and then it says measure number of department digital media views per month. Could you explain like how that is related? Is that a good measure? Is that a typo? How is that a measure of those goals?
You're talking about all those measures or just the last one?
Well, it has 3 goals, and then it says
Right.
performance measure is number of department digital media views per month.
Yeah. So with program-based budgeting, the health department was divided up into discrete programs, which was a different way of budgeting than we had before. And so the health commissioner's office and activities in the health commissioner's office all got grouped into this one category: health analysis, information, and strategy. So there's many sort of varied activities that take place within that program. One of those is our opioid work, and so that's why the naloxone indicator is there. One of it is our communications work, and so we do paid media campaigns, we do social media, we do a lot of other things to educate people about health-related issues. And so that is one measure of how successful our communications activities are, is the number of digital media views.
Do you report, for example, how many of the 20,000 plus naloxone doses you have distributed?
Yes.
Okay. And so what does this represent for me as a councilman looking at this summary? Because I would think that if a goal is to distribute 20,000 plus naloxone doses throughout Philadelphia, that you would say, well, we were 95% of our goal, or 85%, or we did 10,000 doses. So when I read number of department digital media views per month, I'm not sure how to read that in terms of my job in trying to look at this. Can you give me some guidance in how I should look at this?
Well, I can say it's difficult to come up with a measure for how effective our communications are. We have many different channels, and this was just simply one thing that we could measure to get a sense for how much we were engaging with the public on health information and education. And so it is hard for anybody to look at that and say, okay, yes, this is good or bad, but that is one indicator we have for communication.
Okay, I have the same question for administration support. Strategic goal, assess and adjust program fees, fines, and other revenue sources. And then the performance measure is % of fleet vehicles compliant with preventative maintenance schedule. Median number of days to conform department draft contract. So how is that a measure, or should I look at something else? Is there additional things? How does that tell me, or what should I gain from that in terms of my ability to understand how you're reaching your goals?
Right. So, I mean, the goal, the objective that's written there doesn't tie directly to those performance measures. That unit does a variety of support services for the rest of the health department. They maintain the facilities, they maintain the fleet, they process contracts, and so the measures there are ways we can measure the quality and effectiveness of those support services. The objective there was more for something we were going to be doing different this year compared to the routine work, and the performance measures are more for the routine work.
Okay, are you telling me, this is my interpretation, that there might be 50 measures of the ability of your department, this department, to reach the goals, but you picked out one as kind of a sample measurement, like if you're actually maintaining your vehicles better than before, it's an indication that overall the department is performing better?
Well, these are among the things we could count that measured how this particular unit, whether it was performing effectively.
Is this a good measure? Do you think this is a good measure of whether or not, and I don't know that you wrote this, but what I'm saying is this for me a good measure that you're reaching your performance goals by measuring this, as opposed to measuring something else?
You know, all performance measures are imperfect. They get at that particular issue. They don't get at the wide variety of things that you do. So that the preventive maintenance numbers there, that is important to make sure that our fleet is working so that we can out there and do our work. I forget the other numbers out there, but each of those numbers is valuable in its own right. Does it measure all the activities we do? No. to measure all the activities we did, even in that one program, would be 30 measures. And we were told for program-based budgeting, try to have it be very limited. And so the numbers are small, so they don't measure everything.
The reason I bring it up is because my colleague, Councilwoman Maria Quinones-Sanchez, typically asks these questions of how do you measure for success, and I do agree with her. And so I do look at these things as well. It's just a concern on our part, and I want to be able to tell, are we funding things? Are they working? If you provide us the measurements of success, we could kind of see how things are going. And while those measurements may be important for the expertise in your department, I couldn't tell from this. And so if it's possible to somehow provide to us measurements that we could tell, like we're trying to distribute 20,000 plus and we distributed 30,000, then I'd say, oh, okay, I could measure that. But otherwise, it's really hard for me to measure based on these type of standards.
Again, I would just simply say that any measure you have is imperfect, and especially when you have a unit that's more of a support unit to the rest of the agency, it's hard to come up with measures that are easily translated into something that people understand. We have some other measures across the health department that are easier to understand. For example, for HIV, we have the number of new HIV infections per year. That's going down, and that's important. But
that makes sense to me. I was on the board of a hospital. They measured like whether someone gave an aspirin, and I understand why that, as a sample measurement, is an indicator of overall performance. That's really your field of expertise more than mine. But these ones are difficult for me to understand. That's really what I want to say. I want to be able to understand in a more kind of practical way for me whether or not we are hitting the goal set. And I think the term I heard was accurate and more accurate. So if you could provide for us some type of measurements that are more understandable, that would be very helpful. And that's true for everybody, I think. But anyway, that's my observation and request.
Okay.
Thank you.
Thank you.
Thank you. Thank you, Councilman. No other questions that are here?
Okay.
Thank you very much, Commissioner, for coming back. Thank you all.